Good afternoon, everyone, and welcome to today's webinar hosted by the University of Bath's Institute for Policy Research and Department of Economics. Thank you for joining us online for this, our second instalment in our series on health policy. My name is Matt Dixon. I'm a reader in public policy at the IPR, and today I'm delighted to be joined by Elaine Kelly and Toby Watt from the Health Foundation. Elaine is Head of Economics Research at the Real Centre at the Health Foundation and a Senior Research Economist at the IFS. She is also Deputy Director of the NIHR Health and Social Care Workforce Policy Research Unit. Elaine's research focuses on various aspects of health and social care, including variation in healthcare use across time, space, and different patient characteristics, end-of-life care, the nurse labour market, and the low-paid health and care workforce. She has a PhD in economics from University College London. Toby is Senior Economist at the Real Centre, where he runs a programme of work on health and care demand, focusing on in-depth econometric analysis of large data sets. I'm very much after my own heart in that. Today, Elaine and Toby join us to discuss healthcare during lockdown and the future of healthcare demand. The COVID-19 pandemic and the lockdown and social distancing measures accompanying it have resulted in large changes in how patients use the NHS. Today's presentation will examine how use of emergency care and GP services changed after the lockdown was imposed and the potential drivers of those changes. We'll then discuss the possible implications for future NHS activity and population health. Before we begin, there are just a couple of housekeeping notes that I will share with you all. First of all, please note that your cameras and microphones are off and will remain switched off throughout. If you have a question, do submit it using the Q&A function on Zoom, and we'll aim to respond to all these questions during the question time later on. The session is being recorded, so filming and photography are taking place, and subject to no technical difficulties, the recording will be available soon as a podcast and a video on our website. Again, thank you all for joining us, and I'm now going to kick off today's webinar by handing over to Elaine.
Hello, thank you very much for the introduction. So I'm just going to share my screen. Okay, so Toby and I, as was said, are work in the Real Centre, which is a new research centre within the Health Foundation. It stands for Research and Economic Analysis for the Long Term, and the aim is to provide independent analysis and research to help support better long-term decision-making in health and social care. So we launched last month with a launch report and a lecture with Andrew Dilnott. So next year there's lots more work in the pipeline. We also have a major external funding call. So watch this space. So today we're going to be talking about healthcare during the lockdown. I've now added lockdowns, given that when I agreed to do the talk, we'd only had one, and what that means going forward. So, as has been widely reported, the COVID-19 pandemic and accompanying lockdowns have resulted in a huge shift in how people use healthcare, both in England and across the world. Now, what's happened is a combination of several things. The first is deliberate policy choices aimed at ensuring the COVID-19 patients were treated, but also reducing risks to non-COVID patients. So we have in the early parts of the pandemic, there was a decision to sort of cancel non-urgent procedures, both so that there was enough space in ICU to cope with the COVID patients, but also not to put those non-COVID patients under any kind of, to reduce the risk that they would then catch COVID. There's also been changes in the behaviour and decisions that patients have about when or whether to seek care, and also to a sort of lesser degree, those treating them. So doctors also have to weigh up the risks of sending someone to hospital when they know that might increase their risk of catching COVID. Lastly, there's been the lockdown, particularly that accompanied COVID. The two lockdowns have changed prevalence of certain conditions because people have had to change their activities and people have to stay inside, which will tend to reduce the incidence of other infectious diseases. So in this presentation, we're going to describe how COVID and the accompanying lockdowns have affected two areas. The first is emergency care, and the second is primary care. So I'm going to talk about emergency care, and then I'm going to hand over to Toby to talk more about primary care. Now, clearly, we're not going to be able to give you a complete picture of everything that's happened, but we'll maybe give you a flavour of what we know so far. Okay, so I'm going to talk about emergency care. And that was a big focus early there's a big focus in the public policy debate, but also of our work. So we looked at A&E, which hit the news in sort of April, but also thinking more broadly about emergency admissions through A&E and ambulances. I'm going to talk through sort of 4 sets of published work that we wrote about lockdown 1, and then I'm going to try and supplement with that with some information that we have available for, on lockdown 2 that shows you what might be happening now. 2 lessons I think that I'd like you to draw from this. The first is to remember that the NHS is a healthcare system, and so considering one service in isolation can provide a complete picture. Often it's the case that for some conditions there are multiple ways in which patients can receive help. The second is that the impact of COVID-19 and the lockdowns vary across types of conditions and patients. So in most cases, the impact has not been good. There are, as often the case, there have been some, I suppose, winners or some people who have gained from particularly social distancing. Okay, so I'm going to start with a sort of chart, the data that hit the headlines in April, showing that in the spring, that showed really huge reductions in the number of people going to A&E. So that it fell by more than half. Now, there was obviously, in one sense, if it had stayed the same, that probably would not have been good, because we were trying to stop people having interactions with healthcare services that might lead them to get COVID when they could have been treated elsewhere. But on the other hand, there are other conditions where that degree of reduction led to great concerns that there were people whose health was going to be harmed, and they had increased risk of very ill health and death by not seeking help. So that the question really is, to understand what the impact of those are, we need to understand who the patients are, what they did instead, and actually what happened to them. What we did first is very early in the pandemic is to think, okay, well, we know what's happened to emergent A&E visits, but can we think more broadly about emergency care? So here we've looked at year-on-year changes in A&E visits, emergency admissions via A&E, and ambulance incidents in February, March, April, and May. Now, the first thing to notice is that there are very big reductions in both major and minor A&E units. The major units are places that you would go, an ambulance would take you if you were in a major road traffic accident, or you had a heart attack or a stroke or something along those lines. Minor units are more kind of minor injury units. What we see is there is still very concerning kind of 40+% reduction in April going to major units, but the reductions have been larger in minor units, which sort of suggests either people, well, it could be many things, but people may be treated elsewhere. It may be that people could avoid going. It may be that there are conditions that just didn't occur, for example, minor sprains because children aren't going out and playing football. The second thing to notice is that there's clearly been a change in how health services deals with emergencies. So we see, particularly in April, but also in March and May, big reductions in the number of people taken to A&E, even though ambulance calls have actually stayed pretty flat. And the reduction in the numbers taken to A&E, it amounts to about 20% of the total reduction in the number of A&E visits to major units. So it's not that people are being treated it's not that that's accounting for everything, but clearly what's happening in A&E is a fairly complex story. Then we also see that ambulance crews are treating, as a kind of counterpart to that, are treating far more people at the scene. So where they can, they're keeping people out of hospital, again, because they're balancing the risk of, do they need to go to hospital, or in fact, is it safer for those patients to be treated by ambulance crews at the scene? Now, this chart is what was really worrying the government and people in the NHS in the early part of the lockdown. So this is showing year-on-year reductions in A&E visits for acute conditions where we really think there's no firstly there is no alternative to going to A&E, and also it's probably not the case that the prevalence of this is being reduced by the lockdown. It's that these are conditions where you really should go to A&E. What's quite interesting is that the reduction starts prior to the lockdown, which suggests that there's been some behavioural change. But really, it's the heart attack, people going to the A&E for cardiac conditions is sort of more than 50% down, which was really worrying and prompted in early April Chris Whitty, the Chief Medical Officer, to be very clear that it was extremely important for people, if they had these conditions, that they should go to A&E. And we'll see later that this seems to have helped a bit in the following lockdown. You can see as lockdown goes on that there is a recovery, and actually depending on the data source, by the time you get to mid-May, you're kind of around about the levels that you would expect. Now, then the question is, well, we know that for certain conditions there was this reduction, and that reduction was not because of a reduction in prevalence, and those people could not have been treated elsewhere. And so, what the consequence of that has been? Now, that's probably going to take a very long time to unpick, but there is some emerging evidence of what the impact of that has been. So, this on the right-hand side just shows you a paper that was published in Heart in, I think, September, by Wu Mamas Mohammed et al., which is looking at excess cardiovascular mortality between March and the end of June, and they find excess mortality of around 2,000 people, 2,100 people, which is about an 8% increase in 2000 in the same over what you would expect. So that's suggesting that this lockdown has contributed to more people dying of. Now, nearly half of that occurred in the community, and it didn't relate to COVID-19. So it's not that somebody who is in poor cardiovascular health got COVID-19 and as a result died. It seems that they died from a heart attack during that period. Now, the conclusion is that their conclusion, which I think is a reasonable one, is it seems that the lockdown has sort of, delays in care have really led to this excess death. And it's probably not that they've gone to hospital and they're getting worse care; it's that they weren't able to get the help they needed. Another piece of evidence that isn't in this paper, but I think is quite interesting, and I'm going to try and follow up on in due course, is that every month the National Ambulance Syndromic Surveillance System publishes there are syndromic surveillance of ambulance calls, and this is published, in fact, weekly, and it says that daily calls shows that daily calls for cardiac arrest were up 60% in late March, early April. And if you remember from that previous chart, you have a big reduction in the number of people going to A&E and a big increase in the number of people calling ambulances. Now, it's kind of hard to interpret that without more information. We don't know whether people have left it too late. We don't know what type of heart attacks they are, for example. Monthly data, which is what I was referring to before, is available on on cardiac patients and what happened in ambulances, but that's not being published till January, so we followed that up. It's hard to interpret, but again, it points towards people not seeking help during lockdown 1, and that having an impact, a very negative impact on their health for particular conditions. On the other side, we see that there's been persistent year-on-year falls in A&E visits for conditions where it's likely that prevalence has been reduced. So here you see infectious disease and respiratory conditions where it was kind of, but whereas when after the lockdown, as opposed to the cardiac, which started before the lockdown, you see a very sharp drop in the number of people going to A&E for those conditions. And that's kind of, it gets to less than 50% of what is expected. And then it doesn't really recover very much. And that's likely because there has been a true reduction in prevalence. There are people who there's people who are not getting sick with, I don't know, gastroenteritis, for example. It's also the case that there will be people with chronic conditions that are often where visits to A&E are often triggered by viruses, that they are also being protected. So there will be people who have severe asthma who didn't end up going to hospital in the spring because they didn't get sick because they were in lockdown, who otherwise would have done. So those, while we don't think there are any winners from this, there has been some benefit to health for some patients who were not exposed to viruses. Okay, so understanding the different impacts of lockdown on different conditions and different groups of people is kind of important for understanding this chart, which I found really interesting and really stark when I saw it. So here it shows you visits to A&E. The visits to A&E have fallen much more for children and young people than they have for adults. So for illness, you get reductions of 55 to 65%, look very different from adults. And then the same is true for injury, apart from for toddlers who tend to have accidents at home anyway. Right, so children's use of A&E really illustrates actually the importance of understanding the impacts of lockdown on prevalence. So most of this there were a few cases in the spring of some very tragic cases where parents did not take where children did not receive the care that they needed quick enough, and that is of course awful. Most fortunately, children don't get seriously ill as often as adults, and most of the reductions that we saw in children's use of A&E can be explained in both differences in the underlying burden of disease they get, so what diseases they tend to come in with, and also the different differences in the impact of the lockdown on their lifestyle. So children are more likely to visit A&E with illnesses related to infection that would be suppressed by the lockdown. So in the first 20 weeks of 2019, about 2/3 of visits to A&E from children were related to for either respiratory, gastroenterological, and ENT infections. That's versus 42% in adults. It's also the case that some of the chronic conditions that children have tend to be worsened by infections, and also to some degree for asthma, a pollution that would have been suppressed by the lockdown. Epilepsy, interestingly, I found out, is because if children with epilepsy get gastro bugs, their drugs tend to come back up, and then they can have epileptic fits, which is why you see reductions in epilepsy. It's also the case that children's lifestyles were more curtailed by lockdown, so they were not key workers. The children go up to 19, so there were a few at the top end, but most children were at home, and therefore their activities were curtailed much more than were adults, many of which were key workers going around about their work and business. Okay, so this is to illustrate. So children, there was a bigger reduction in children, both because they're more likely to get these three conditions, they're more likely to come into hospital with these three conditions, which would tend to be suppressed by the lockdown. They also have bigger reductions in these illnesses, which leads them to that picture of that stark picture of the reduction in A&E visits. It's also the case with injury. Those injuries, these are kind of those 5 common injury categories. Children are more likely to get these kind of minor injuries from playing sport and so forth, and they also have slightly larger reductions in in the number of A&E visits. Okay, and as you can see, none of these are really increase. Well, yes, things like there aren't that they haven't recovered, at least by the end of by May. And interestingly, you see, particularly for respiratory conditions and ear, nose and throat, they still remained pretty low into May. Okay, so what do we know about lockdown 2? These are charts that are just taken from the PHE syndromic surveillance reports that are published every week. So this was data up to the 17th, I think, of November, and you see that there was a very big drop in late March, followed by a recovery largely up to normal levels, and then there's been a slight reduction in the first couple of weeks of the lockdown, of the second lockdown, but nothing like the first lockdown. What we see if we look at cardiac, which was really one of the areas of concern last time, there was a very big dip, which, as I said, was accompanied by other things like big increases in ambulance use for cardiac. You see that since then, since kind of early May, this is slightly different data, which is why the times are a bit different from the earlier chart. And we see that there hasn't really, that it's actually been above trend, which is interesting. I don't quite understand that. And there hasn't really been a dip in the second lockdown. So it seems that the message that's been very clear from Chris Whitty and Boris Johnson and so on, that it's important to go to hospital if you have a life-threatening condition like that, or if you have any condition that you think needs to be seen, has really helped maintain attendance. And it's interesting that I looked at some data from the US recently, and they still haven't recovered the level of cardiac admissions. So I think that suggests that messaging and ensuring that people know what they should be doing is really, really important. By contrast, asthma visits are still below trend. You see a peak around the return to school when everybody's child, including mine, got a cold. And that kind of triggered asthma. But then since then, and again with the lockdown, you see asthma below trend. And the same is true with gastroenteritis. So this has been an extremely good year not to get a tummy bug. Right, in summary, in the initial lockdown, A&E visits fell because there were changes in how care was delivered. And that was both, and that was to do with policy induced, but also probably some changes on the ground based on what clinicians thought was the best for their patients. Some patients with acute needs stayed away from A&E, and early evidence has suggested that this might have contributed to the excess mortality, and but also that the prevalence of other conditions fell, particularly other infectious diseases. Now this will return at some point, as we saw with asthma around the return of school, but at the same time, it's not that there's pent-up demand. It's not that there's an asthma attack that you didn't get treated for in April. And early evidence from lockdown 2 suggests that more people are going to A&E for acute conditions, which is really positive, and that the prevalence of other conditions is likely to be suppressed by the lockdown and remains lower than it was last year. Okay, I'm going to stop sharing now, and then I'm going to pass over to Toby to talk about primary care.
Hi, thanks, Elaine. Hello, everyone. I'm just going to share my screen. Okay, yeah, so I'm going to talk about primary care. We've done a lot of analysis on this over the course of the year, and it's mostly been using something called CPRD, which is a patient-level primary care data set, which has allowed us to basically get hold of some very interesting information. So primary care use during the first wave, there was quite a big change, as you can imagine, with everyone in lockdown in that first period. So primary care is the main point of contact. It's this is something I think we need to, there's a fact check here, but it's something like 80% of all sort of healthcare contacts are undertaken in primary care. And the main challenge, so the advice for people when approaching primary care during the lockdown was to, especially if you had COVID symptoms, was to call NHS 111 and to self-isolate. So the main challenge for primary care appeared to be how to maintain care for people without COVID-19 and also limiting the risk of infection. The NHS Digital, so the high-level data showed us a 30% reduction in primary care appointments in that first period, as well as a dramatic shift to remote consultations. And here we're going to look at those data, and because we have patient-level data, we're able to have a look at how that activity changed for people of different ages. We look at gender as well, but also because of the patient-level data, we have access to patient history. So we know if people have pre-existing conditions, and we can see how things have changed on that basis as well. This analysis fed directly into NHS England DHSC during that crisis response. The problem is with primary care, the lack of data and the lack of information means that primary care is very poorly understood, and there's a couple of good reasons why. Firstly, it's very complicated. So because it's your first point of contact, you go to your GP presenting with basically anything. Also, they're all individual kind of companies and entities, and data recording is not, universal. Here is a representation. It's kind of our work in trying to describe or get a handle on primary care and how it works. But as you can see, there's lots of complications. We don't necessarily know just by looking at the appointments data whether someone is presenting with a new illness or going for a checkup. There's a triage process which has been instigated since the beginning of lockdown, or since the first wave. And then you have face-to-face appointments and non-face-to-face appointments, and then all of these other things can then kind of happen to you in that primary care flow. So you are either referred to secondary care, you undergo tests, and there's GP prescribing as well. So first of all, I'm going to talk about consultations, and then move on to discuss kind of the primary care outcomes as we call them. So throughout the first period of lockdown, there was lots of advice going out to GPs in the build up to that first first lockdown, particularly, as I said, NHS 111 and for people to self-isolate. GPs were also told to limit or completely stop the number of the routine referrals that they were providing or offering. Importantly, they were also asked to maintain the 2-week wait referral rate. So we're going to talk about that a bit later, but a 2-week wait is if a GP is suspecting that their patient has cancer, then they make a referral, a very urgent referral. That means they're seen within 2 weeks. And then there was also guidance to GPs on who are most vulnerable to COVID, and therefore who they should be shielding. And there was advice also on how to continue that care. And that was in the 2 days before lockdown. So consultation rates in this period had a big fall. This chart is probably more complicated than it needs to be. But this sort of solid black line just shows the average number of consultations per person, and then by age as well. And we see this drop here is around 30%. The dotted line is so that we can align these data with the kind of national NHS digital data, which looks at appointments. And we can, so when we were first using these data, it was at the beginning of the year. So we wanted to make sure that at least we were kind of broadly reflecting what was happening in the national accounts as well. as you can see, there are a couple of different kind of shifts. So particularly here you see a big drop in activity. This is related to the Christmas period, so you don't have many GP consultations happening over the kind of winter holidays. The red line shows the start of lockdown. So on March the 23rd, the week that week is where the red dotted line is, and you can see after that week there's a big fall. We think this is around 30% in terms of activity. But there's, interestingly, that first week there's a jump in activity for elderly patients, and partially for the sort of 50 to 70 bracket as well. And then you can see with younger patients, there's before the lockdown, there's a tail off in the number of appointments that are happening. And if you compare sort of the numbers before and after, the percentage fall is larger for younger patients as well. And we're trying to figure out why that was. So what we did was we separated our patients into by their pre-existing illness. So this shows that same consultancy data, but it splits patients by whether they have a pre-existing illness. And this start of lockdown on week 12 brought with it a massive spike in the consultation rates, but particularly for people with COPD, with cancer, and with asthma. So patients that are particularly vulnerable to COVID. The hypothesis here is that people hearing about the lockdown were contacted. So in line with that advice to GPs just before lockdown, these are your most vulnerable patients. You need to figure out how to maintain that, how to get that continuity of care throughout that first lockdown period. And the purple line at the bottom is for people without pre-existing illness. So younger patients or patients without pre-existing illness who are considered less vulnerable, and they experienced kind of an earlier, so they didn't have a jump during that first week of lockdown, but also their kind of percentage fall compared to what we would have expected was much larger. So now we're going to talk about prescribing, which is one of the outcomes, and then talk about other outcomes as well. So with prescribing, you can separate it into two kind of clumps. One is repeat prescribing, so people with pre-existing illness just need to kind of update their prescription. And then new prescribing is a new presentation of illness or kind of a new drug or a new treatment offered to patients. Repeat prescribing is much higher, it's more frequent, it's more often. And what we see here is the quantity of repeat prescriptions jumped even before the lockdown. So patients and GPs, or the combination, was kind of preempting the lockdown, understood that it was happening, and made sure in whatever way possible, a lot through e-prescribing. And these kind of bits of prescribing don't rely on a consultation to happen before in order to pick up your drugs. New prescribing is much less frequent, and it did experience a drop-off. At this point, we're trying to figure out what's happening in GP consultations, because there's no kind of uniform way to know. There's no data that says, right, well, or we haven't got to it yet. This person came in for a headache. This person came in with abdominal pain. This person came in with, persistent, gastroenteritis issues or something like that. We just don't know what that is. So we're using the new prescribing data to try and figure out what's happening in terms of the kind of case mix for patients that are arriving into GP practice. This graph shows the actual fall in new prescribing compared to what we would have expected had there been a fall in consultations. And the lines kind of match up. So what we think this tells us is that the fall in consultations is what's driving this fall in new prescribing. As in, if you do go to see a GP during that first lockdown, you're no more or less likely, as a percentage of the sort of GP consultations that are happening, to be prescribed a new drug than you sort of were before lockdown. which I think is quite an interesting result, indicating sort of hinting at what's happening in terms of case mix for people that are going to consultations. We're also going to look at follow-ons. So these are split into kind of 3 categories from that sort of web map from earlier. We look at immunizations, we look at tests, and we look at referrals. The immunizations, you can see this big spike, which happens around winter. That's, flu vaccinations for elderly patients. Testing is sort of GP practice testing, so blood tests, etc. And all we do is we look at a simple count of these. We're fairly new to the data, so we're thinking about ways that we can dig in. And then there's referrals as well, which I'm going to talk a little bit more about now, just because we were able to split those by urgency. And you can see before the lockdown, in the weeks before lockdown, these were already starting to tail off. Particularly referrals dropped a great deal and have started to recover, but for several weeks or even months during the lockdown, the referral rates were much lower than we would be expecting. If we look at this, so this does make sense. This makes a great deal of sense because GPs were asked to stop routine referrals. Routine referrals are also the most common, and we see here that they are at their highest. They're the highest of the 4 kind of categories, and they drop very steeply in the run-up to lockdown, in sort of in line with advice. But what's worrying about this is that we also observe a drop in 2-week wait and other urgent referrals. So as I said before, the 2-week wait is relating to a suspected cancer case, and the other urgent referrals are sort of other life-threatening illness that aren't necessarily cancer. They hold a higher weight in terms of the amount of time it takes you to be seen in secondary care. Here we observe that they fall and then recover. So this shows the same as with the new with the new prescribing. What we would have expected to have happened had with the fall in consultation rates that we observe. And basically, this shows that for both 2-week wait referrals and routine referrals, there's a big drop in the rate per consultation, which is worrying, but and has implications for sort of cancer and serious illness outcomes. What we don't know, but what we can kind of hint at from the previous kind of analysis, is that this reduction in 2-week wait referrals could be because of a lack of people presenting with new illness in primary care, which makes sense as a kind of as a patient. People didn't want to go into engage with the service. People were worried about wasting health service time and not wanting to be a burden on the health service. There was a lot of rhetoric around the impact that COVID was going to have on patient beds and doctors and nurses, etc. So if people aren't presenting, then you can't refer. And despite kind of there does seem to be a response in terms of an encouraging response, because around sort of when this data started to come out, we observed letters to GPs from NHS England saying, please make sure you see your patients, make sure there are these 2-week wait referrals, make sure they come through. So we do get a recovery. However, it doesn't make up for the reduction in consultations that we're observing. We also did some analysis on the impact of remote versus face-to-face consultations. So we can observe in the data when a GP refers to a consultation, whether they talk about it being a remote or a face-to-face consultation. Now, here again, we present this split by ages, and we compare our data to the NHS digital data that's available, and we see that there's a jump from kind of between 10 and 20% of consultations happening remotely, up to 50%, which is a huge swing. Other pieces of analysis that people have done have found these to be higher. So the data analytics team at the Health Foundation looked at Ask My GP practices who were kind of primed for that digital service, and they found 90% of consultations happening. So there's obviously going to be a huge amount of variation from practice to practice in terms of kind of the patient mix and the practice readiness to engage in remote consultations. And further work that we do, we'll definitely have a look at that. What we also do, just quickly, is we split we have a look at the referral rates for the consultations, but based on whether they were face-to-face and whether they weren't. And understandably, the number of referrals happening from remote consultations in the pre-lockdown period was very low, and it gathers very quickly after lockdown. So we see a change here in the so you have greater frequency of remote consultations, but also the referrals per consultation are higher in remote consultations than they are in face-to-face consultations. This, again, we're kind of reluctant to draw conclusions on this because all we're observing is the overall activity. So we can't see necessarily whether it's patient behavior, GP behavior, or a combination of each which is driving these changes. But this kind of fits as well, I think, with the hypothesis that it's possible that remote consultations are more likely to contain new presentation of illness than face-to-face consultations. So it looks a little bit from the data like the face-to-face consultations that are occurring for patients with pre-existing illness. In terms of the new prescriptions, that kind of works in the same way, and we see a very interesting flip in the rates of new prescribing per consultation. So the new prescribing, it does a complete reverse in the post-lockdown period. So what used to be the rate of new prescribing per face-to-face consultation is now the same as the remote, and vice versa. So that was a little bit of a whistle-stop tour, and basically there's huge amounts of information in here. It's very difficult to cover in such a short period of time. So if anyone wants to kind of pick this up, obviously we've got the Q&A, but afterwards as well, I'm very keen to kind of to figure out what's happening here. So primary care has experienced a shift to remote access, but we still observe the drop in consultations. So the increase in the remote consultations didn't make up for the reduction in face-to-face. We've seen a shift in the outcomes of those remote consultations and that indicates a shift in the content or a shift in the patient GP behavior, but we're not 100% sure which is which. And the largest fall in appointments are for patients without pre-existing conditions. So it looks like continuity of care for patients with pre-existing illness is being managed or relatively well managed. And the fall in 2-week wait referrals is very worrying. This is indicative that missed appointments contain more instances of newly presenting illness. So if people haven't been pre-diagnosed with an illness, they're less likely to approach a GP about it in that first lockdown period. And as with most interesting things, this is throwing up more questions than it is answers at the moment, and we're developing a program of work to try and figure out exactly what the best thing to do is with this. So thank you very much. I'll finish and we'll go back to Matt. I'll stop sharing my screen.
Thank you, Toby. Thank you, Elaine, as well. Thank you for those presentations. So much. Whew, my mind's a bit blown with so much information and so many interesting patterns that you've highlighted. We've got questions coming in, so I'm going to kick off straight away with those. First of all, just for Toby, just to clarify, when you talk about primary care, is it just GPs that we have the information on, so people's contact with that, or does it include other professionals like pharmacists and optometrists and those sorts of primary care appointments?
Yeah, so the data is there for all of them. For this analysis, we focused on GPs and practice nurses because we had to figure out some way to kind of define a consultation. One of the interesting things about primary care is how it's changed over the last kind of 20, 30 years. What a GP used to do isn't the case anymore, and the kind of the primary care staffing roles have changed a great deal. So trying to figure out how that's happened is going to be a huge part of our work for the next, kind of few years. And the data is there. It's just we did this in a bit of a rush, trying to help with that COVID response. So we kept it quite focused in this instance.
Okay, and there's another kind of follow-up question, I suppose, that's related to that, and that is asking about, do we know anything about variation in tasks that, from doctors to other primary care staff or nurses or nurse practitioners or something? Do we have any information on whether the kind of who picks up the roles, who picks up the tasks, any changes in that?
Yeah, so what I guess it does go back to the data. If we the way CPRD works is that every time any member of a primary care staff, whether admin, whether nursing, whether GP, opens a patient file and fills that information, it gets recorded.
Right.
So it is all in there. It's going to take a lot of work to try and pull it out. It would be really interesting to have a look at whether those roles, so not only the kind of natural organic change in how primary care works, but specifically, did it change a great deal in response to the kind of the COVID crisis?
Thank you. And actually, there's another question that kind of links to that on a bigger scale, in thinking about Elaine as well, looking at the A&E. So someone asked, the BMJ published letters from GPs saying that referrals that they'd made during lockdown were refused by the hospital, so they're kind of bouncing them back. Is that something you can look at in the CPRD, especially for like 2-week wait referrals?
Yeah, so that's a very interesting point. You can link CPRD to secondary care. So what we observe is what GPs write down. So if a GP writes down a referral, we don't know whether it bounced back or not without being able to check in secondary care. Or I guess we could also look at kind of repeat 2-week wait referrals that occurred kind of within a few weeks of each other, but we haven't done so yet.
Okay, yeah, I mean, it sounds like, the data, that slide you put up was very scary in terms of the kind of matrix and networks of all these interconnected all these interconnected bits of information, and how the different routes people could take. So I imagine, yeah, the data analytics people have got their work cut out, and will do for months and years probably. But yeah, it was great that you've got all these interesting questions to kind of look into. There's a question here as well that's just come in asking whether there are plans to follow up with wider research, so linking in with other health foundation work, such as questioning the community and insights gathered on the ground, that sort of work. Is there a plan to kind of link up with other health foundation projects?
For the CPRD, so what we've done so far is so this analysis that I've just presented came out in a blog, and we there's a research fellow who's also a GP called Bex Fisher who input into this work, and we were very careful to make sure that what we were saying was accurate, or at least feasible in that way through engagement. What's been really interesting in the follow-up has been Q fellows contacting me to talk about the work after the fact, and yeah, it's certainly something that we try and make sure that we do.
So I guess that in terms of the next year, the aim will be probably to continue this work, firstly to understand what's happened, because we only went up to the summer. So what's happened over the course of the year, have there been catch-ups and so on. I think there's also a real interest in inequalities again, and whether there's particular patients, particular patient groups that have been affected, which ties in with this work and our general interest in inequalities, but also ties in with some work that Bex and our one of our research fellows, Mikdad Azaria, who's at LSE, have done on general practice and the fact that those in deprived areas are more likely to be treated by nurses rather than doctors. It's harder to get doctors in those areas. So there is a kind of larger research agenda where Bex is kind of at the heart of it, as well as us economists, thinking about primary care, COVID, inequality, and supply of GP services.
Because that's another question that has come in about thinking about social gradients and some of these responses, and whether you've had any chance to look into the data on that yet, whether it's that certain communities aren't accessing A&E in the same way, or holding back more, or any. Can you say anything on that yet, or is that all for the future work?
Toby, I'll let you answer that.
Sorry, can you repeat? I was thinking about the answer to the next question, which has just flashed up on my screen.
That's okay. This is the joy of live questions coming in and looking at those. But yeah, so just thinking about whether, have you had a chance yet to look into the data in terms of characteristics of patients and social groups, different groups? So if there's social gradients in who's no longer going to the doctor and that sort of thing.
So there are several challenges with that, I guess. The first is that this piece of analysis was done on a very small number of GP practices that were giving us data that was up to the minute enough at the time. So we had 85 practices here, which are sort of dotted around the country. The way CPRD record their data is that they have the IND score of the local area that the GP practice is registered in, not the patient's address. So there are some real issues with getting at the kind of socioeconomic gradient and impact on primary care at a kind of anything other than a small kind of regional level. But again, if you link to HES does record that information. So
HES being
the secondary care hospital episode statistics. That those data are also recorded, also record ethnicity, which is of great interest in terms of primary care engagement as well. And we're basically submitting an application right now that would allow us to link those data sets. So we'll see what we can do as the data progress and as we get a larger sample of primary care providers, and then we can look at that socioeconomic gradient, but just not in the kind of detail that we'd really like to.
We're moving to a much bigger sample as well, right?
Exactly. Yeah.
So how many GP practices would that be, hopefully?
It should be, so there are sort of 6,000 in England, and CPRD manages, I think, around 2,000 practices. So there'd be kind of plenty of variation, but you just worry about how it, like, especially in areas like London, where your GP location doesn't necessarily reflect in any way your local area.
We've got a few more questions come in. Can I sneak a question in before I go to the next one, just to ask, you mentioned at some point, I think, Elaine, about whether we anticipate kind of like pent up demand, for certain things we might do. And you occasionally you get people in the media saying that, thinking more about deaths, that, oh, it's just shifted deaths. By the end of the year, we'll have had the same number of deaths, and people have just died sooner than they would have done, which I don't think is, almost isn't true, right? But do you get the same questions with, are there conditions that actually we've seen these drops and we are going to see a recovery? Recovery in the sense of more and more people going into hospital with these conditions. It's shifted to a different part of the year. Is that something that you can give us any kind of insight into?
From those data, I mean, we know that excess deaths are, there's what they say, 70,000 excess deaths or something. This is probably not all that. There's going to be a little bit of it. There's a lot of people who were in care homes that you've shifted a bit. But you can also see that there are people who had a heart attack who didn't get treated, and as a result died. So I think a lot of the pent-up demand is going to come from, but there's going to be a lot of pent-up demand from the cancer. So
right, yeah,
that's that. So some of that was Toby's. There's you brought deaths forward. That may be true for people who've got COVID. The question is, for people who didn't have COVID, is that also true? Maybe for heart attacks, maybe not, because if you've got a stent, if you've got treatment, you might have survived. But equally, if that means that you're not getting seen at stage 1 or 2, you're getting seen at stage 3 or 4, that's likely to have a very big impact on whether you survive, how long you live. And that is likely to lead to kind of pent-up demand, increases in excess deaths over the next few years. But then there's a set of other conditions where there may be fewer deaths. Fewer people will die of respiratory illnesses, fewer people will die of flu, those side of things. So it's hard to see for certain things. And it may be for older people this winter, like, for example, in London, there hasn't been excess deaths recently, even though we've had COVID deaths, because there have been fewer other deaths, which are probably, pneumonia, flu, that type of thing. Yeah.
Okay,
it's a complex picture.
It's that kind of trying to unpick the data, and good luck to to you and to everyone else who's trying to who's trying to do that. So there's a question come in that's asked about whether you've looked at emergency and primary care use, whether it's changed for people with dementia in particular. Is that something you've been able to delve into?
So that's an interesting, and again, it's the answers lie in the kind of underlying data. So we do have the capability to diagnose patients with dementia, and we've on the work that I presented, there was a list of kind of 10 or 11 different pre-existing illnesses. Normally, if we were doing a presentation of this kind, you would have dementia as one of those lines, so we would be looking at it. The challenge comes in getting the required sort of sample size, because dementia prevalence is so low in the kind of general population. Obviously, COVID has had a massive impact on social care and the social care system. The challenge for us in analysing that is getting social care data, which is so difficult. And I think proper analysis of the impact of COVID on older patients with dementia is particularly challenging, and would rely on that interface between social care.
I think just doing a quick check on the time, I think we've got time for one more question, which I want to ask it with a slightly more positive note, thinking about are we going to see, do you think, some positive changes in the way both primary care and secondary care is done? Are there kind of process innovations? Are there things that in future we'll say, I mean, a bit like with some meetings, you might say, actually, why, from now on, we're not going to bother having that meeting, get everyone to London and do that. We're going to just do it on Zoom because we've been forced to, and actually it works just about. Do you think there's going to be some kind of process innovations in primary and secondary care where we say, okay, from now on, we're going to do this on the phone much more, or we're going to do Zoom consultations or things like that? Are there some positives we can take out of the situation?
Well, it's kind of interesting because you can see that either patients or GPs, we're not sure which, that there has been a change in the kinds of consultations that are happening remotely. And one of the challenges for us is having a look at seeing that reduction in the number of consultations that are occurring. There are questions of whether those reductions are kind of efficiency being borne out, and the kind of any reduction in kind of wasted NHS resource use. I think with what is really worrying about that is as we've spoken about, those 2-week wait referrals and that reduction, and whether the price that we have previously paid on sort of lack of efficiency with a lack of triage that happens in primary care. I don't think anyone would say that it was worth that reduction in those serious or urgent referrals that we're seeing. Elaine, I don't know if you want to.
I think it, as always, there's going to be winners and losers. So yes, it's going to save money, and actually for some people it'll be much more convenient than waiting in a waiting room for hours with a screaming child. But there'll be other people who are put off by it. So it's just trying to find a way of harnessing the good that's come out while not disadvantaging too many people, particularly those who may struggle with English or may be particularly frail, and how you deliver services to different types of people, I guess.
Yeah, I think it's as with all these things, the challenge is going to be to take out those, the useful stuff without, losing that kind of patient care, that in-person, connection, and those important elements of care, and making sure that people, different groups, as we talked about, are going to be affected differentially, and making sure that people don't fall foul of any changes. Okay, I think that's pretty much all we've got time for. Just remains for me to say thank you so much, Elaine and Toby, for brilliant presentations, a lot of food for thought, and a lot of research to be done going forward, which is great for researchers like yourselves and like us here in the IPR and Department of Economics. Thank you to everyone at home for joining us today. And also thank you to Eleonora Fakera from our economics department, who put today's session together, and indeed the whole health policy webinar series. So thank you, Eleonora. As I mentioned earlier, the recording is going to be available as a podcast and a video on our website, and we'll give details of that shortly. And details of the third and final webinar in this series can be found on the IPR website and on the Department of Economics website. So all that remains for me to say is thank you again for being with us this afternoon, and we hope that you'll be able to join us online again very soon. Thank you, and bye-bye.